Good afternoon, everybody. My name is Roger Kirby. I'm the President-elect of the Royal Society of Medicine, and welcome to our next COVID-19 series, where we are looking at today at the pathophysiology of COVID-19, especially in the very severely ill patients. So I'm very lucky to be joined by two eminent clinicians, Dr. Alison Pittard, who is the Dean of Intensive Medicine, and we have Dr. Aine Burns, who is a consultant nephrologist and also a Director of Postgraduate Education at the Royal Free Hospital and at University College London. So please do send your questions in. We have so many questions, I won't be able to put them all to our guests, but we'd love you to send them in, and please do upvote them so it makes it easier for us to choose some questions to put to them. So let's start off with Alison. Alison, just tell us a little bit about the risk factors for patients to get really ill with this horrible virus.
So sometimes it's difficult to actually predict who's going to be worse affected than others, although we do know that the data that we have so far that people who have comorbidities, particularly diabetes and hypertension, are more at risk. People who are obese, men more than women. And at the moment, we don't really know why that is. What we do know is about the pathophysiology and how it's the body's response to the virus that has some of the major impact on the clinical features that we see. And so whether these predispositions mean that you have a different or an augmented inflammatory response to the virus or not is difficult to tell. But obviously, going outside of COVID, patients who have comorbid disease are at increased risk of other things, because particularly diabetes is a multi-system disease. And so patients with diabetes, particularly poorly controlled diabetes, are more at risk of complications. So there's a whole host of reasons what might put individual people at increased risk.
Thank you. And then the question of BAME individuals being more at risk, do we have any understanding of that? Some people say that it could be due to the ACE2 receptor in the lungs, or any thoughts?
Well, obviously there was concern initially about patients who were on ACE2 inhibitors and whether that might increase the risk of people becoming significantly sicker with COVID. That's now not the case, although we do know that the virus gets into the body by binding to ACE2 receptors. What we don't know is that whether the receptor is expressed differently in different groups of people, and particularly BAME populations. So although we do know that they are at increased risk of getting the disease, becoming sicker and having a higher mortality, it's not clear at the moment what the absolute underlying cause of that is. It's going to be multifactorial, and we're not going to find out for a long time yet.
That's good. Well, there's a question about that from Dr. Jahari, but Dr. Tavina is saying, how can I think it's NIV, non-invasive ventilation, as an alternative to intubation? You know, we know our beloved Prime Minister was on the verge of being intubated at St. Thomas's. So just talk us through how you judge whether a patient should be managed with CPAP, and when the intubation and ventilation, invasive ventilation, started.
So under normal situations, irrespective of COVID, it's usually fairly clear to intensive care doctors when a patient needs to be intubated and ventilated. And that tends to be based upon their oxygenation, their respiratory rate, their work of breathing, and also how they appear clinically. But in COVID, the information that we had at the beginning of the pandemic in this country is the experience from Italy. And what they were seeing were patients who are profoundly hypoxic, and under normal conditions, they're the sorts of patients that we would intubate and ventilate. So the advice that we were being given from Italy was intubate patients, almost immediately. There's no point trying them on non-invasive ventilation or anything like that. But what we found then from our own experience, and again, advice coming from Italy, because Italy was starting to run out of capacity, they had patients outside of critical care on non-invasive ventilation, and most of that was CPAP or high flow nasal oxygen. And in fact, a lot of those patients were doing well and their disease started to improve. So we started to change our approach in this country to perhaps trying CPAP or other modes of non-invasive ventilation to see if that would help. Because I think it was the profound hypoxia that really scared us, and thought, you can't have a patient on a ward or not having any sort of invasive ventilation with that degree of hypoxia. But we've learned over time. And so the time at which we would change from non-invasive to invasive ventilation is more on the patient's sort of clinical features rather than absolute levels of oxygenation. So it would be their respiratory rate, their work of breathing, whether they were getting tired, and that would be where we would change from one to the other.
I can ask you one more question, then I go across to Aine, and there's a question about smoking being a risk factor. I mean, I suppose they've got pre-existing lung damage. Well, just tell us a little bit about that, Alison.
Well, smoking in itself puts you at an increased risk, because the contents of the tobacco has an effect on the respiratory system. It has effect on the cilia, your mucus secretion and everything else, and cough suppression. So there's a whole host of reasons why smoking will put you at increased risk of being sicker and perhaps requiring critical care support. But I'm not sure in terms of evidence in the literature to say that there's an increased incidence of smokers either getting COVID, needing to come to hospital, or in fact needing to be admitted to critical care.
I guess there's a good message for the general public: stop smoking and lose some weight. Let's bring in Aine here. Aine, I suppose the renal replacement story that happens a few days after the patient has been in the intensive care ward. It's not an immediate thing. So just talk us through, when you get called to see a patient on the intensive care unit at the Royal Free, how do you make the decision about whether they need renal replacement? And tell us some of the problems that you've encountered.
Yes, Roger, thank you. It's been a remarkable journey, a learning journey, I suppose. We're well used to patients with multi-organ failure and sepsis developing AKI. In this situation, the numbers were, relatively speaking, huge. The renal replacement therapy requiring AKI is usually about a day 9 thing on ITU. At one point in our unit, I think we had 39 or 40 patients on hemofiltration. Hemofiltration is a nice, gentle, usually pretty much continuous dialysis process, and much more easily tolerated by a very sick patient. But that presented us with lots of issues. The pathogenesis of it is probably quite multifactorial again. In the beginning, just as Alison said, everybody was learning lessons about the lung issues. We were also learning that we would normally keep patients dry who have adult respiratory distress syndrome, and it was our kind of first impression that the AKI was pre-renal volume depletion, and this could have been augmented and was likely contributed to by fever with insensible fluid losses, by diarrhea and vomiting and so on, and other GI losses and ventilatory losses. But it's apparent that there are other issues and there are other factors involved. Things like microthrombi within the kidney, just as they were seen within the lung. And there are some reports, I understand, of cortical necrosis, where the renal cortex is irreversibly damaged, but many patients are also getting better. There was a lot of muscle injury, and many of the patients, even who don't end up on ITU, and many of my colleagues indeed, suffer muscle aching with high CK levels. So that may have contributed a little bit. And we know that the virus can actually, it has been demonstrated within the proximal tubules. So reabsorption of things like bicarbonate and maybe even water in collecting ducts and so on is all likely to be impacted. What's strange though is it doesn't seem to be an immune mediated thing. Looking for immunoglobulins within the kidneys of patients who have died of COVID-19 doesn't seem to have yielded anything to date. So patients would present to us, if you like, in nephrology in usual sort of way with climbing ureas and creatinines, hyperkalemia, and with oligoanuria and usual sort of intravascular volume issues and needing to give drugs and blood products, for example, in somebody who's oligoanuric. You end up requiring to make space, if you like, with renal replacement therapy and remove some of the toxins. So
great. Well, Dr. McCarthy is saying could he be interested to hear about the gastrointestinal involvement, because I suppose if they've got diarrhea as well as respiratory problems and renal problems, that's going to make renal replacement difficult. And then let's also ask you about the hypercoagulability and specific problems relating to that, Anya.
Yes, well, I've seen figures around 17 to 20% of people have GI issues, and I've heard of colleagues worrying about mesenteric ischemia. And I think the things are there in nephrologist world. Diarrhea and vomiting usually means intravascular volume, or leads to intravascular volume depletion, and we think of pre-renal injury. But there are other diarrhea-associated illnesses that lead to microangiopathic hemolytic anemias and so on. And the fibrin thrombi that are seen in the lungs and indeed now in the kidneys might suggest that there's an element of microangiopathic thrombi going on. And it's been quite interesting because not only have patients' circuits clotted more often and people have needed to give more anticoagulation during the filtration and indeed dialysis processes. In our dialysis unit, patients who were clotting circuits who wouldn't normally ended up having a COVID test, whether they had symptoms or not, and some of them were found to be positive. So there's definitely a pro-coagulant signal that is now well recognized, and it has to be dealt with, I think, on a case-by-case basis, because there are patients who have suffered hemorrhagic problems as well. So getting the balance of anticoagulation right is really important, I think.
And in terms of treating patients right now, I mean, renal dialysis is one aspect, but I guess you have to decide between whether to give them heparin to deal with a hypercoagulability problem. Do most patients get heparin because of the risk of pulmonary emboli and brain infarcts?
You mean patients not on renal replacement therapy, or those or all patients?
Yeah.
Okay, so what our intensivists have been doing is measuring D-dimer levels. They have a low threshold for doing CTPAs, and I understand from one of my colleagues that 50% of our ITU patients had CTPAs, and 40% of those have had definite evidence of pulmonary thrombi. He believes that there are more patients, and sometimes you can't see them because they may be in the small vessels in the periphery of the lung. So we're having a low threshold for anticoagulating patients, but not trying to do it carefully and not recklessly, if you see what I mean, and trying, and likewise, I think our cardiology colleagues are seeing thrombi in the coronary vessels that are not related to plaque rupture, which is quite unusual. So a low threshold for anticoagulation dictated by radiological evidence and D-dimer levels.
Right. Let's go back to Alison. Alison, they said on the radio this morning there have been 7,000 publications on COVID over the last 3 months. So it's pretty difficult to keep up to date with this. And there's a lack of evidence because they haven't had time to do the trials, although people are saying that the NHS is perfectly placed to do a lot of the really important studies. And here at the RSM, we're encouraging people to put their patients into trials as much as possible. But in the absence of evidence, just talk through some of the options that the intensivist has in a really sick patient on a ventilator in terms of treatments that might make a difference.
Well, it's really difficult to actually give treatment specifically for COVID when there's no sign.
Whoops, just losing that signal.
Sorry.
Sorry, we lost you there just for a minute.
All right, I'm back, am I?
Yeah.
So we're because there's no scientific evidence as yet to say that any one drug may work or be better than others. The advice is not to give any experimental drugs outside of a trial, because obviously we don't know what the risks would be to giving patients. So although there's lots of potentials and lots of other people are saying, oh well, you should just give it, we have to remember we still have normal people who happen to get COVID, and we shouldn't treat them any differently to anybody else. We wouldn't use drugs that haven't been proven in any other situation. And so in the absence of specific treatment, the only thing that we can do in intensive care is support patients. We know from things like swine flu and other influenzas that the treatments, what they tend to do is to limit the duration of the disease and may reduce the severity of it. But even so, people still get it. People are still sick when they come to intensive care, and we have to support them to allow their body to recover.
There's a good question from Peter Borg-Bartolo saying it's likely there'll be long-term pulmonary and renal complications from COVID. I mean, this is the sort of post-ITU syndrome that I guess we're anticipating will affect. Any thoughts about that? And then Anya, any thoughts about long-term renal problems in these patients? Start with Alison.
Yeah. So from the respiratory aspect, again, it's not just the respiratory system that is problematic following critical illness. We know that whatever brings patients into critical care, they do have problems afterwards getting back to their pre-illness state, and it can take 12 to 18 months to recover from critical illness. And then particularly if you've had a respiratory disease and you have permanent damage to your lungs, it's not clear as to what level of activity you'll get back to afterwards. And obviously we're in very early stages of the pandemic at the moment. What we do know is that support for patients recovering critical illness is under-resourced, and we try to follow up our patients, but not everywhere has capacity to do that. We're going to need to support patients more, particularly after COVID, and we need to do that as quickly as possible in the community, because otherwise people are going to have to stay longer in hospital because they won't be able to get the support outside in their own home environments. And that's going to have an impact on the ability of certainly the acute care setting to start to restore normal services. So it's going to be really interesting to see how COVID affects patients differently. And I'm sure it will do because of how sick they are when they're on intensive care.
Thank you. Anya, long-term renal effects, do we know yet whether these patients are going to have long-term renal problems?
I think the short answer is we don't know, Roger, but for some of the patients, they're already diabetic and hypertensive. And for some of them, it's unmasking and perhaps, and will undoubtedly, I think, actually aggravate their underlying renal condition. So we will have to deal with the fallout of that, I think. There may also be subtle renal tubular problems, and we're asking our respiratory colleagues to make sure they dipstick urine and measure things like bicarbonate. And then I come back to the sarcopenia and the muscle loss, because we traditionally measure kidney function, of course, using creatinine. And creatinine is a product of muscle metabolism. And so if you've lost a lot of muscle, your creatinine may appear good, but you may be falsely reassured that the renal function is better than it is. So I think we'll be very careful in our follow-up, both of our patients who have existing chronic kidney disease, either known about or emergent, if you like, during COVID, and those who've developed acute kidney injury. And I think there'll be a lot of work and learning coming out of that for us.
Well, Anya, you're Director of Postgraduate Education up at the Royal Free. So I'd like to ask your opinion about the impact of this COVID-19 crisis on the doctors working at UCL and at the Royal Free. I suppose it's mainly the younger trainee doctors who are taking the main brunt of the impact. Is that true, or?
Yes, but first of all, I'd like to say they've been tremendous and they've stepped up very much to the plate. And as a profession, I think we are in no danger of not having a worthy group of people as we move out of this pandemic. But nevertheless, it has been very stressful. We've had trainees pulled out of, say, for example, ophthalmology, histopathology, and join acute medical rotas when they haven't been on a ward, a medical ward, for 5, 6, 7, 8 years. So we've tried to focus very much on well-being, both physical well-being, providing evidence that people care about them, and emotional and mental well-being, and providing psychologists access to various apps, mindfulness, and so on. And just yesterday, I got the results of a survey of our trainees, and by and large, I think they're doing very well. They have concerns about the impact of this on their educational opportunities. And in the background, there's lots of anxiety about their families and friends, which we need to be mindful of. But I think trusts around the country, I'm hearing, have really tried to look after their staff. And I hope that the legacy of caring for staff will be a silver lining in this disaster, really.
Any thoughts about that? We're almost running out of time, Alison, but I mean, you're based in Leeds, but you must have feedback across the whole country. I mean, the intensivists, are they getting stressed out by this scenario, or are they coping with it?
I think they're coping to a degree, but the longer it goes on, the more stressed people get, because we can't maintain the current levels of activity in the medium to long term. And I think one of the major concerns is that now that the NHS is trying to restore some of the services that have been suspended, there's still hospitals that are way over their normal capacity. And the thought of having to start supporting some normal services is daunting, because they don't know how they can maintain that current level of activity. So I think that's the concern, that they've been running on their adrenaline for weeks, and at some point that will run out. And so we've got to make sure that any plans going forward, because we're going to have a medium-term plan to be able to support more normal activity and COVID stuff. And that's going to be a challenge, because we need to make sure that staff are resilient going forward.
And any thoughts about the risks to patients coming in for other types of illness into a hospital where you have a large number of patients on intensive care with COVID? I know there are some scare stories about severe risks to patients undergoing emergency surgery. Any thoughts about that briefly?
Well, obviously people have been concerned about coming into hospital because we've seen a huge drop-off in attendances at the ED and patients presenting with chest pain and things like that. So these are some of the unintended consequences. And what everyone's been trying to say is the NHS is still open for everybody. So please, come in and be seen. And what hospitals are trying to do is to look at new models of delivering services to try and make sure that there is no cross-infection in the hospitals. So yes, if you were going to come in without COVID and go into the system as it is currently or was before, then there will be a very high risk of contracting COVID. So we have got to look at ways of separating the service. And that's obviously a new thing going forward. And every organisation will be looking at how it can do that in its own footprint.
It's going to be based on testing, I suppose, which is raised in the House of Commons at Prime Minister's question time yesterday.
Yeah.
So testing is probably going to be the answer to create COVID-free zones to make it safe for patients. And do you think that the long term, the profession, how long do you see that the excessive stress on intensive care lasting, Alison? Is it beginning to improve now? Can you see a perceptible improvement?
It is beginning to improve. So even those areas that have been heavily hit by this, starting to ease off, but still well over their normal baseline capacity. And of course, going forward, it may be that instead of delivering critical care in one area, you're going to have to deliver it in multiple areas to keep COVID and non-COVID patients separate. So I think going forward, even if you're at normal bed numbers, baseline bed numbers, they may be in different parts of the hospital, and that is still going to put pressure on staff and on services going forward. So we're going to have to look at adapting the way that we deliver care, even if that's just for the medium term, but also adopt some of the positive changes that we've had to implement during the pandemic. Because just the digital platforms that we're using now has transformed healthcare, and so we need to make sure that we adopt those and embed them in our services going forward.
And one last question, Anya. I mean, the Royal Free and at UCL, you've expanded the intensive care units dramatically there, have you? I mean, how much bigger is intensive care there now compared with how it was, roughly?
Well, at our peak, we were double the size that we normally are. So, and we exported a couple of patients from Royal Free site, which is where I am, down to UCH, and a couple to a handful to Nightingale. And we expanded into all sorts of areas. Another word, I think, about supporting our staff as we go forward, I think the effects of the traumas, that the psychological traumas will be long-standing as well. And our trainees, I think, will have to be very careful that we continue to support them as well. So I think the physical, if you like, busyness and work is diminishing and hopefully will remain diminished. But as Alison says, we've got lots of challenges in terms of restoring some sort of business as usual, giving patients the confidence to come back into the hospitals, and looking after our staff who need to continue doing that.
Well, that's a perfect last word for us, because I'm afraid we've run out of time. I'm so sorry we didn't get a chance to answer some of the fantastic questions that have come up, but in half an hour, we don't really have time for all of those. We will have a session at the end of the month, and we'll try and address more of the questions. So thanks to our speakers, Anya and Alison. Thank you to the audience for being so attentive and sending in your questions. Please do support the Royal Society of Medicine, who's working very hard to support the profession through this COVID-19 crisis. Farewell to all of you. Please do tune in next Tuesday and next Thursday for our continuing COVID-19 coverage. Thank you. Goodbye.
Thank you.